Okay, and here we are. Welcome. Welcome, everyone. And Lauren, good to see you again.
To see you. I'm loving the wintry look today, although I
I,
don't really like the white stuff.
yeah, fully embracing it because there's no other choice. So yesterday was the first official snowfall, and I feel like I'll permanently be in a hat now, but that's okay. It's finding comfort in the day to day and rolling with it. So, we today, everyone, we are glad to have you on if you're watching live. Um, I welcome you. And if you have any questions, feel free to type them in the comments of the live video that's streaming now on Facebook. And know that you can message me at any time if you just want the recording. We're recording right now on Zoom. And if you've not seen or have not had the chance to request the recording from about 2 weeks ago, I guess that was with our initial Zoom,
Mhm.
and then I'm happy to share that. We will be breaking that down and creating a fun little tidbits that are going to keep the information flowing out there on the socials. But to sit down and watch the whole thing and then prepare other questions for us is really what we want. Lauren is a wealth of knowledge, and when it comes to women's hormones and health and how it's affecting your day to day. If you know from our first conversation, we had talked all about the different ways it might surface, the changes that could happen from, say, 35 on up when you're talking about premenopause, perimenopause, and through into menopause. The fluctuations that are unsavory, uncomfortable that we're dealing with that we want to know how to not just help those symptoms and kind of calm them down, but maybe what are some things that we can do to ease them, and especially leading up to before we even get into those phases, what are the things we could do? So, Lauren, just kicking us off today, um, what would you say? I'm just curious from our first meeting and first little Zoom session. What would you think was the most impactful nugget that we had shared? What do you further want to impress upon everybody? Was just the general knowledge of what are our hormones, understanding them fully, how they go to work in our bodies, and how they affect our day-to-day health. I think that was just the most basic coverage of important information that we can probably get across.
So it's really important to understand that our hormones all have an interplay. It's like this woven kind of dance. I think of it kind of as like a ballet or a symphony. Like you just think of this very fluid motion. Our hormones are messenger molecules, and literally every cell of our body has most of the hormone cell receptors on them. So when you think about all these strange perimenopausal and menopausal symptoms, they're not so strange because in actuality, we have those receptors on those cells. So, like estrogen receptors, the most amount of estrogen receptors on a cell are actually really pulled together in a very tightly woven interplay within the brain. So how many women talk about having forgetfulness or having brain fog or having, any kind of more mental health challenges? Well, if your estrogen levels are depleting, which we'll talk about, when that happens, that's likely to be one of your symptoms. Same with like musculoskeletal issues, which was one of my biggest issues. And think about like having the receptors of all of these different hormones and not just your sex hormones, which I hate calling them that because they're not truly just driven for sexual reasons, but that's kind of the classification that people think about. So if I say the word sex hormones, I mean estrogen, progesterone, and testosterone. Um, those are the three that most people are aware of. There's some others that we might talk about, but the way in which hormones as a whole interplay, and the reason why I've decided that in my practice, I'm not just going to focus on perimenopause and menopause in the sense that just those three hormones are going to be studied and balanced and everything else, is because you really have to start at the adrenal gland. And the adrenal
Mm.
gland is this little triangle gland that sits above your kidneys. So you have one on either side. And when you go from premenopause, so pre premenopause is more of our baby making fertile years. Then we talk about, perimenopause, and then we talk about menopause is literally one day. People don't realize menopause
Mm.
is the day that your period has ceased for 12 full months, a full year. Then the next day you're postmenopausal. So it's just
Mm.
that one day. It's that And,
Yeah, it's
and
always
it's
thought of as,
fine if
oh,
you
it's a
don't,
phase, a whole
yeah,
phase, but
yeah, and
interesting.
if you and it's fine if you don't know that, because there's many different reasons why you might not know that. You might have had a surgical, intervention, hysterectomy, or an ablation to your uterine lining. You might have an IUD in where you don't get any kind of um, you know, bleeding of any sort, or you just have spotting, and that's fine. Like, we don't have to have an actual date of your menopause. And it's easier to have a date now because of tracking apps and Aura rings and all that kind of thing, but it's not necessary. Like, we can look at some blood work, we can treat you with symptoms, and that'll be fine. So I just don't want you to feel like I'm less of a woman or I need to know this actual date. You don't. So let's start again with the adrenals. I can get off track and squirrel
Good,
quite a
good
bit.
tangents, but all important information.
So the adrenal glands is what they make your cortisol, and everyone's heard about cortisol. So what I was getting to is when you're premenopausal, you're actually in a very ovarian centric stage of life, right? Because your ovaries are functioning and they're there to make the eggs to then, bring the eggs down the fallopian tube and get fertilized in the uterus if that's what happens. So you're having this ovarian centric time of life in your 20s to mid 30s. And then we go as we move towards, perimenopause and menopause, you're becoming more adrenal centric, which means that you're really, as your ovarian function is dampening and decreasing, diminishing, that's when your body kind of flips over to the adrenal glands. And that's what's supposed to kind of carry us through the rest of our life. So it means that we need to be even more gracious with ourselves and really be gentle with the way in which we absorb the stress. And it's crazy because this is the time of our lives that I feel like we're the busiest. A lot
Mhm.
of us are in this phase in our early to mid 40s where we have kids that are in all kinds of activities. Like, I'm just thinking of like not every woman's this way, but just thinking of like what a lot of us are dealing with. And you just feel like you're all over the place, go, go, go. And that could be just a busy woman in general, whether it's with her job, whether it's with her furry children, whether it's her, human children. And everyone these days is heightened and just go, go, go. So your
Yeah.
adrenal glands produce cortisol to help, dampen the stress response. Well, when that doesn't get dampened, and throughout the day you're just riding high, day after day, year after year, you're just at this high level of cortisol, then what starts to happen actually is your body will then start to increase your blood sugar as well. It's trying to also respond to this stress response. And so when your blood sugar then increases, your insulin level is trying to take that blood sugar and bring it into your cells and work with it. But if you have so much blood sugar out there, the insulin can't scoop it up and bring it into the cell. And your insulin then elevates because it's trying to handle all of this blood sugar. And what's
Mm.
crazy is people don't realize, like, we link diabetes to diet all the time, right? And a lot
Mhm.
of times it is. I mean, it could be just the standard American diet. Maybe you're more sedentary, but there are plenty of people that become pre-diabetic and diabetic solely on their stress response.
Mm.
They could have good diets. They could be
Mhm.
eating all the protein. They could be eating just whole foods. But if they are not doing what I discuss as stress dips, like, you have to have these parts throughout your day that you're breaking that stress cycle, whether you
Yeah.
take a walk for 10 minutes, whether you're breathing for, you're doing your favorite pattern of breathing, whether you're journaling, whether you're meditating, like, and it doesn't have to be long periods of time. But the stress dip is so necessary. Relaxing your shoulders, just getting up from your computer after, X amount of time, setting a timer, those things are just really invaluable, because if you keep having that cortisol response, I'm telling you, the blood sugar goes up, the insulin goes up, and
Mhm.
then also what happens with cortisol is you can be hypercortisol, and then it starts to dip down, and then you become hypocortisol, which a lot of the symptoms actually look very similar, but it's your body trying to, like, protect you. There's a lot of things that happen in our bodies that people don't realize are more just a protective mechanism.
Mhm.
So the adrenal, the blood sugar, the insulin. What happens is, though, if you have high cortisol and high insulin, that precipitates low thyroid function.
Mhm.
All interwoven there. So what happens is those elevated cortisol, elevated insulin will then create more of a il- like more of a lack of conversion, lack of a high quality kind of conversion of our inactive thyroid to active thyroid. So our T4 to our T3 hormones within the thyroid gland. So that's where, like, you know a lot of the same symptoms that we talk about fatigue, or we talk about hair loss, or we talk about, you know, sometimes being cold, or weight gain, and all of the things that can also be perimenopause, they can also be related to thyroid function, low thyroid function. And there's an epidemic of low thyroid function that's not being diagnosed because the testing methods in which we use aren't as well, conventionally, what we're doing is not really looking at and evaluating the thyroid the way that you should. We're all taught in medical programs, and that's where I feel uniquely. I've come from a traditional background. I also have the functional background that I then got later on, but I understand and I know what I was taught there. And we're taught to look at the TSH, and I'm sure everyone is familiar. Like if you say something about thyroid symptoms, okay, we'll check a thyroid level. Well, it's really checking TSH is a thyroid stimulating hormone, which means that it's what your brain is doing to stimulate your thyroid. So what's the quality of stimulation of your thyroid, not your actual thyroid function.
Mm.
So if that is in a normal range, which we've talked about last time, that normal is not optimal. And none of us here that are interested in our health want to be in a normal range, because that's 95% of the people out there.
Mm-hmm.
Not what I want to look like. You want
Right.
to look at this tighter window.
Yes.
um, that's where, even if this TSH is not in the tighter window, if it's still even a little elevated outside of that window, anywhere in that range, you're still not looking at the thyroid itself and how you're converting, how you're producing, if you're blocking in one aspect. And that's what really drives treatment, and the treatment in which you need, because there's different types of thyroid treatment. So that's not something conventionally I was taught. It's if the TSH is good, then we're not even going to go to the next level. And the only next level that tends to be looked at is the T4 level, and T4 is the inactive. So we're not even looking at T3 really ever.
Mm.
And that's your active thyroid. So why would you only want to know what the level of your inactive thyroid hormone
Right.
is? So, and then there's two antibodies which aren't looked at. One might be looked at depending on if you already have a history of autoimmune conditions. The other
Mm.
one is typically used as a thyroid cancer marker, and like kind of like a progression. And so I've gotten backlash before when I've drawn that, and doctors and other clinicians don't understand, because again, they don't have the functional lens to look through things. So
Mm.
those two antibodies are what we want to look at, because women are at a much higher risk of Hashimoto's, which is the autoimmune thyroiditis. So we want
Mhm.
to look at the entire thyroid. So we've gone from the adrenal glands to with the elevated cortisol, which elevates your blood sugar, which elevates your insulin. So insulin resistance is one of those big buzzwords, because weight gain comes from that.
Mhm.
Certainly diabetes, if you're on that insulin resistant spectrum, then eventually you hit that diabetic mark, and all of a sudden, one office visit, you're diabetic. Well, you've been trending that way for years.
Mm.
That's where, when you ever actually get a diagnosis, it's
Mhm.
not because all of a sudden from 6 months ago at your last appointment, or a year ago, all of a sudden this just flipped and changed. No, if you actually look at the trending, lab markers, they've been slowly creeping up and elevating, but they've still been in that normal window.
Mm.
So normal is normal, but as soon as you get out of that normal, if you're at that way elevated, so the insulin level goes from like 4 to 25.
Mm.
That's huge.
Too
Like
broad.
optimal
Yes.
is 5.
Mm.
4 to 5 is optimal at the low end. But if you're 25, you're still pre-diabetic until you hit 26. And that's
Mm.
even if they check an insulin, because a lot of people don't even check insulin. They just check
Mhm.
blood glucose, which is a stress response. So that's where it opened my eyes a lot when I finally, out of necessity for health issues that I had and my children had, that I really found kind of this side of medicine, which again, I hate that we're not just integrative, and I see more of that happening, but we still need to really fuse together and understand that this is the way we're going to heal, the
Mhm.
Western world. I mean, really,
Yes.
you know.
Yeah. And
So
everything that you share there, I mean, it's fascinating to me. This is knowing the basics, getting to hear more about this type of testing and the preventative side of this, where no matter where you are, like you said, okay, this is, you look at the markers, you look at the different things, the levels in the blood, and you're seeing trends. You're able to nip something in the bud before it gets a little bit too out of hand, or slow the process of something getting so that you are not you're not becoming diabetic, or adrenal fatigue. I mean, when that begins to happen, and then say the exercises that you were doing before are not working for you now, or is causing more of a detriment, then these tests and these things that you could find out are enabling a person, to be able to course correct, right? And maybe make some subtle changes in their lives and their habit and their lifestyle, that can kind of keep them on the better, healthier track, from developing a disease that they, can hopefully prevent.
Absolutely. The thyroid is the canary in the coal mine. So, with function there, if your function is lower, it's telling you that things are brewing. And we
Mm-hmm.
live in a toxic soup of it's just the way in which we are. We're not living in the same that our grandparents lived in. There's no
Yeah.
way. We have the environmental stuff, we have the food related, we have the products, the traditional products we're all putting on, like all of that is really hitting us hard, and our bodies are trying to push back in a protective way. They're trying to push back against us, and that's when people develop allergies, and they develop eczema, and they develop
Mm.
other rashes and acne, and all of that stuff is your body pushing back against what it's exposed to, what it's ingesting, what it's breathing in, what it's whatever. And the skin barrier is not a barrier, it's a sponge. So as you
Yeah.
put things on your skin, it's
Yeah.
actually really soaking into your bloodstream, and people don't think about that either.
Yeah, that's a big thing. And I mean, it's only, I guess, a more hot topic within the last several years of when you hear somebody say hormone disruptors.
Mhm.
That I knew this from a while back, thinking if you're smelling a perfume, you're smelling an air freshener, you're putting stuff in the air.
Yep.
It's a molecule that you are taking into your nose. You're putting something on your skin. It is absorbing. It is going in. And if you can smell it, that means that there's a chemical scent, and then that is becoming part of your bloodstream, is becoming part of you. And when you talk about hormone disruptors, there's so many, whether it
Yep.
be something you're smelling or putting on or cooking with, or eating
Yep.
from or drinking from. And there's so much, to consider, which
Right.
there are steps we can
And a
take.
lot of and the consequence of a lot of that, you made a good point, that all of that, number one, fragrance itself, like
Mhm.
traditional perfumes and any product that has, it says fragrance, it says perfume, or it says parfum, which is the French word. Any of
Mhm.
those words, like, you should really avoid, because that is a proprietary blend of all kinds of chemicals that you
Mhm.
don't know what's a
Mhm.
part of. So it can be from 10 to hundreds to even 1,000 or more little, kind of recipe of these chemicals within whatever product. And there's buzzwords out there, and unscented yet still has scent, or natural and is still a synthetic fragrance. And it's unfortunate. And you really kind of have to pick apart, and it just comes through trial and error. And I've been duped, and I've been doing this for quite some time, and even still, like, there'll be things that the way in which things are written, and it's just that those words I would really try to keep out of all of your products. And the traditional products, you look at the back of a lit of a shampoo bottle, conditioner, soap, whatever, and it's like 20 or more plus ingredients. Like, you
Yes.
just can, you can hydrate your skin with tallow. You can use essential oils mixed in,
Coconut oil,
and
and
stuff,
yeah,
all
natural.
kinds of stuff
Mhm.
that are just really truly, like, what you're getting. And the same with our food, right? We talk about that all the time. Like,
Mhm.
look at this. Do I understand what this is in a package, or do I know that this is meat? This is apple. This is, it's
Yeah.
looking and knowing and acknowledging, like, what is in front of you, as opposed to, like, I don't know what these chemical words are and these scary words. But what
Yeah.
happens is those endocrine disruptors. So people come in, I think I'm having a hormone issue, and they may or may not be, but you might not see it in blood work when they're just having more of this kind of fluctuation of these xenoestrogens, so these disruptors, the phthalates, the parabens, the all of
Mhm.
them, that are changing the ratio between your estrogen and your progesterone. It doesn't mean that they're out of range, but when the ratio is elevated and your estrogen is higher than your progesterone by quite a bit, that's when you start to get symptoms. That's when PCOS happens. That's
Mm.
when hormonal acne happens. That's when insulin resistance happens. Like, all of that shift of just having that ratio a little bit different, and having less progesterone than having more estrogen, like that does start to really create that dysfunction. So when people say this word estrogen dominance, and to make it a scary term, like having too much estrogen is bad. Number one, we have thousands amount like in the thousands when we're pregnant,
Mm.
you know, as opposed to like our periods, we tend to have like levels that are in like 250 to 500, several thousands when we're pregnant, you know, but then the menopause range is like 20 and under. So you can see like we really do bottom out. But it's important to know that that difference there is where there's a lot of dysfunction. So hearing the estrogen dominance title is not really fair. It's more of a progesterone deficiency than an
Mm.
estrogen dominance, but it's that widening of the two ratios that really does create quite the stir in the body, and these
Mm.
hormonal changes that a lot of women, you know, feel, but then they might get some labs done and they're like, oh, you're fine, you know, and that's where a lot of the dismissive, because the levels are normal, but it's not that functional side to be like, okay, you know, we really
Mhm.
need to eliminate this and we need to do that, and also add progesterone, but that's not something also conventionally talked about.
Right. And
So
so to that point, so when someone comes in, they want their labs drawn. You can look at everything and make a judgment on, okay, what's the next course of action for that individual. So tonight, the topic today is hormone replacement therapy, and what exactly is it when you're talking about if someone is they're low in progesterone, they're higher in their estrogen, their levels are off, or there's different ways to attack this. I know very little about HRT. This is a therapy that many women that I know are already dipping into. There's different forms of it. So, what can you explain just the basics of what it is and who might want to look into
sure.
this
Yeah,
course?
absolutely. Let me just go back quickly so I can piece it all together. But the
Yeah.
adrenals with the cortisol, the elevated blood sugar, the elevated insulin, then that impacting the conversion of your inactive to active thyroid function. But what happens is elevated cortisol and elevated insulin and low thyroid function also then impact the production of all of these sex hormones. So that's
Okay.
how it all kind of plays together.
Yeah.
So, but we really go in this kind of hierarchy of order that the adrenal gland is the master, like cortisol is the master hormone, and it really is like the head, the conductor of the symphony. Okay. And then
Hmm.
the rest of them kind of follow suit. So if we're having this dysfunction at these levels, then that's where the sex hormones also can become dysfunctional, and possibly even earlier. You know, you would think it's interesting because you would think that maybe we'd be going through menopause. The average age of menopause is like 51 and a half. You'd think
Hmm.
that that would be changing. It's not changing by all that much. You would think that maybe like kind of the toxic nature in which we live in, like maybe that would shorten, and maybe we would start earlier, but we're really still seeing it around 51 and a half. But depending on when you go through it, it can start up to 10 years beforehand. So
Hmm.
the vast majority of women, you know, still maybe in their late 30s, early 40s, certainly by mid 40s, where I'm at, like my symptoms started 2 years ago. So
Hmm.
for me, like, I don't think I'm going to make it to 51. And that's not a bad thing if you're already replacing. But if
Hmm.
you're at, you know, an earlier age, depending on like what health issues you might have had before, if you did have a hysterectomy, if you did have your ovaries taken or not taken, which I can explain, women, oh, it's fine, I still produce my estrogen, my testosterone, because I still have my ovaries.
Hmm.
Well, let me just tell you that when you go through any surgery, and I've been in these surgeries before, hysterectomies and others, what do they have to do when they take an organ out? They have to clamp the arteries and the veins
Like, beat it.
wherever, you know, the blood supply led to. So they clamp the ovarian arteries on either side while they're taking out the uterus, and
Hmm.
then they unclamp them. Well, diminished blood flow diminishes hormone production. So that's
Hmm.
not something that's ever brought up
Yeah.
either. So you're not going to have 100% of your production when you had a hysterectomy and you don't have and you do have your ovaries still.
Hmm.
You'd have more obviously than if you didn't have them anymore, but still like that blood flow, in this, you know, the blood flow that was diminished in surgery definitely makes a difference. So let's go to HRT and who would benefit and who wouldn't. Really, you know, it's not that we want to push it on everyone. It's there's two camps here. There's more studies and more information about the preventative benefits now, and there's a school of thought like I want to get on it, and I want to be, if someone's like a biohacker or they're really invested in their health and they really kind of want to optimize everything initially, why not? Why not see where your levels are? Why not, come in, and even if you're not having any symptoms yet, like there
Mhm.
are um there are statistics where, we start to drop our bone density 2 years before menopause. Well, you might be one of those lucky ones that doesn't really have any symptoms before menopause, but
Mhm.
still knowing like, okay, like just kind of seeing where I stand, if I'm in that age range, if I'm in my early 40s to mid 40s or whatever, like you could be one of those people that come in and just say, hey, like I would just like to see where I'm at. And honestly, we'd be testing your thyroid too, and so many women have low functioning thyroid that that could be something that you're optimizing there. And then the hormones, the sex hormones are great, and that you don't need to go any further. But a lot of women, they start with sleep is often times the most disrupted and the initial presenting symptom, because what happens is our progesterone declines usually starting in our like 30s, mid 30s to late 30s. Our progesterone is kind of on this slow decline, kind of.
Mhm.
But our testosterone starts a little bit later on its decline, maybe late 30s, early to mid 40s. And it's not as it's not as steep of a decline. It's a little bit more gradual, but still kind of stays low and goes bottoms out. Now our estrogen, what that does is it just becomes this crazy chaotic mess. And I can tell you, and I have no problems telling, I'm appreciative for what I've gone through, because it gives me empathy for other women going through it too. But what happens is you might be riding fine for, some time, and then all of a sudden you might have this giant estrogen spike, or you might have this big bottom out. But it really gets you to understand and know your body and know your symptoms. So
Mhm.
I can tell, all of a sudden I could feel like I just did the hardest workout of my life. If my estrogen level has bottomed out, that's what'll happen to me. And I find that every 2 to 3 months, I'm having like a change in symptoms that I know I have to change my dose of progesterone, testosterone, estrogen. That's me. But I've learned that as
Mhm.
I've been kind of going through this up and down, mess. I saw this picture once of like, it was a graph in a study, but it was showing all these estrogen levels. And it seriously looked like this abstract painting, because it was like the levels were all over the place. And that's why we feel so crappy sometimes, because you could be all right for a few days and all of a sudden you have this dip, or you have this crazy, what they call a loop cycle, which means that your estrogen might go crazy high. And you
Mhm.
also not need to know, as a practitioner, that while you're in that perimenopausal state, like you might have a level that goes crazy high, and you just recheck that, because in a couple days, guarantee, that's going to change. It's just the nature of perimenopause, and it's this moving target. Perimenopause,
Mhm.
that's what it is. So you got to have grace for yourself, but you got to also realize, like, yes, the progesterone's going down. Yes, the testosterone is also going down, and a little bit more of like a shallow kind of decline, but the estrogen is just kind of all over the place. So trying to maintain and steady out that estrogen is really what's needed in perimenopause. And there's so many different vehicles to do that. Everyone's probably heard of the patch, and that's the most common to start with. But there's gels, there's sprays, there's actually almost like a intravaginal ring that can give you localized or systemic. There's two different ones that can give you systemic, um, internal kind of levels of estrogen, or just local estrogen in a ring. There's two different. So
Mhm.
there's a bunch of other options in the toolbox. When it comes to that, when it comes to progesterone, it really, if you have a uterus, you need to protect that uterus against proliferation while you're giving estrogen. Estrogen is a wonderful hormone, but people get nervous because they think it's going to cause breast cancer.
Mhm.
And thank goodness, 2 days ago made a huge advance. The FDA and the HHS, they finally combed through lots of research studies, and also had a whole panel of a lot of experts. And many of them up there were actually mentors of mine, that were explaining why this black box warning, this major risk about increased dementia, increased breast cancer, increased cardiovascular events, including clots, that was all on the estrogen packaging. And it was false. It was false because it was all encompassing of um, risks that weren't there as a whole. It was unfounded. They had it on vaginal estrogen, most prominently, and that certainly doesn't have any of those risks.
Mhm.
It's all in the way in which you take things in, and that's where knowing someone as a whole is super important. So you don't come in and just like, we're not in silos. And that's unfortunately what we learned in conventional medicine. Like we learned this system, we learned whatever system, this, and that's how they had actually our syllabus, like our syllabi partitioned out, is we're going to learn this system, then this, then this, and this. It's not this whole kind of interconnectedness that we really are as a human, species, which is the most amazing thing about it, is really we were created that everything really does interplay with each other.
Mm-hmm.
So it's important for people to realize, like, we might talk about an option for you that's not going to be an option for someone else. If you don't have any issues with gallbladder disease, you haven't had any fatty liver diagnosis, you haven't had like anything related to upper GI stuff, like we might talk about an oral pill for you with estrogen, which is like, what? Take oral estrogen? Well, yeah, oral estradiol is fine if you don't have any risk factors. That's it, all is in which you way in which you metabolize. And for those that don't have that issue, that could be an option for you. And that might be, especially if you're a younger woman that's on the go, and a pill is better for you and easier for you than to keep track of a patch or insert, XYZ. So that's where having that time and having that discussion and knowing the person and really getting to intimately like have that. And okay, like, I want to know what your day-to-day life is. Are you a woman who travels? Like, are you a woman that lives between two houses like you do? Are you a woman that, excuse me, that's just so crazy busy that that's going to be one extra thing she can't handle? So that's where finding out what in the toolbox is going to really be helpful for you. So I don't know. I'm just going
Yeah.
off the cuff. So
Well, and that's really what my question was, is like with all the different forms and types and ways that it could be prescribed. I mean, how was that even chosen? And you just basically answered that it depends on the lifestyle, depends on health history, but whatever's going to be the best and most convenient for that person, which is great if there's not some universal treatment or universal fix. It's depending on the
right.
woman and what her
and
lifestyle.
and that's where, like, conventional medicine is wonderful, but I feel like a lot of the conventional practitioners, number one, they don't have the time to sit and have these
Yeah.
conversations.
Mhm.
And then also they usually have like their one thing that they'll try, and if it doesn't work for you, then it's like, okay, well, sorry, maybe we'll try again some other day. I mean,
Yeah.
that's really, and I get it, but it's not enough, and we deserve more. So to be able to sit there and to show you all of the options, explain out all of the options, and then we have shared decision making. And I've always prided myself in any facet of medicine I've practiced. I always sit there and I give you choice, and I want you to make the decision. I'm there
Hmm.
with you, and I will give you that information, and we will talk it out. But ultimately, it's your life, it's your lifestyle, and I want you to feel comfortable with this. And you might start with something, and we might have to tweak things. Like, we might have to decide, you might try this and, like, you know what, I don't really like the texture. I don't really enjoy putting this on. Okay, great. Let's try something else. I mean,
Hmm.
it's kind of like, acne, in the way that, like, people just accumulate a bunch of different products. I feel like in perimenopause, I feel like, I have a bunch of different doses of different things and everything. And, that's been a lot of people's acne journeys, right? Like, they've tried different things, and they have like their whole box of all of their over the counter products or prescription products, and things work certain seasons and not. And I feel like in perimenopause, it's the same way. Now, when you hit menopause and you get your sweet spot and your combination, like, usually you're good. Usually, like, you can ride on that combination, whatever works great for you. But so it comes from either the preventative side, and ultimately most women have some kind of symptom, and if they don't have a symptom, they really should at least think about vaginal estrogen, because there's a syndrome that every woman goes through that's called the genitourinary syndrome of menopause. And whether you don't, if you might not have the dryness, you might not have the irritation, you might not have the pain during sex, you might not have those, but all of your cells in your bladder and in your vagina are actually changing. So they go from an acidic to a basic pH. And what
Hmm.
happens when that happens is we actually are at a much higher risk of urinary tract infections. And that is one of the hugest killers of women after being hospitalized and then becoming septic from UTIs. That's a huge killer among women.
Oh, you've got to be kidding me.
No.
Okay, so that's
And so, like, having the vaginal cells change, and that's what happens in every woman. It's with the lower estrogen, um that does that shift. So women that have more bladder infections, this interstitial cystitis, a
mhm.
lot of times that's more of a lower estrogen kind of a thing. It's not truly, there can be some other reasons, but a lot of women, the urgency, the frequency, the incontinence kind of issues, that can also be related to like the lower estrogen states.
Hmm.
um but every woman really, there's one like contraindication of like this very rare uterine sarcoma, but everyone else, even active breast cancer patients, everyone else should be on vaginal estrogen. It does not go systemic, it stays localized, but it also protects your vagina from changing. And also, when we don't, it's crazy, but when we don't reintroduce vaginal estrogen, the inner labia, we have outer labia and inner labia. Sorry that this has become like an anatomy lesson, but the inner labia actually like disappear. Like part of our vagina disappears, which is
Interesting.
horrifying, right?
Yeah.
Like it
Yeah.
shouldn't happen. Right. So the inner aspect, like it does, it starts to shrivel up and like disappear. And it's all because of our low estrogen states. So
The
the
change of the
UTI
cells.
risk and all that, we
Yeah.
should all just be put on estrogen, like blanket, like 50. Like every woman by 50 should be on vaginal estrogen.
Yeah. So
I
when you
mean, it's
say
really,
that with just a couple days or 2 days ago, the change of the black label, and now I feel like this is this whole new movement that can happen where the conversations are already being had. People are already curious about how this can help them, and the stigma will go away. I mean, it's going to take some time because I think it's
yeah,
just in women's brains that this is going to be a detriment. It can cause cancer, breast cancer, or whatever. But getting the message out that this is not the case, that's never been the case. Like you said,
right.
was it back in the 60s that wasn't label there and
It was
people
given
are
out,
took
yeah,
it.
60s through 90s. It just started that day, that year after this WHI study that created this buzz in the news, and the news really kind of ran with it. And all of a sudden, we have this like increased risk of breast cancer. Well, there was a reason for that. There was a certain synthetic progesterone,
Hmm.
progestin that we don't even use anymore, and that was really the culprit. That they saw this slight increased risk of breast cancer. We don't use that one anymore, and it's never been founded by. And in fact, there's actually a decreased risk with the estrogen alone arm of that study. So they didn't want, they wanted to sensationalize like the risks, and that just like screwed all the women for the last 2 decades. But the estrogen alone arm of this study, because there was the estrogen plus this synthetic progestin, and then there was estrogen by itself. And the estrogen by itself actually decreased breast cancer.
Mm.
And also what they've noticed in studies is that women that, estrogen is a proliferative type of hormone, and it's something that it proliferates cells, and there's hormones that do that and there's hormones that don't, and that's fine. It doesn't mean that it's bad,
Hmm.
but what women have to understand too is like you have to keep that in check, but you also have to know, like, you have to be doing proper screenings, mammograms and everything, just to make sure there's nothing that's there that it might proliferate, it might continue to grow and feed. And progesterone actually also keeps that in check, and progesterone is the hormone that's an proliferation type of a drug, which is why we give it to women with uteruses, because when they're on estrogen, you want to make sure that those cells are not proliferating and growing. So, but from the preventative aspect, like a lot of people a lot of women that are using it for that reason is because it does actually decrease the risk of dementia. It decreases the risk of even colon cancer by 30 to 40%, and pancreatic cancer by 50%. That was a recent
Amazing.
study. It also decreases, um, let's see, cardiovascular risk. It improves bone health. It decreases, fracture risk by 20
Hmm.
to 40%, depending on which area, in the which bone location you're talking about. Like there's astounding benefits to these hormones.
And so
So,
when do
so
you say
there's,
is the good time for the preventative side? If that's what, I
yeah.
mean, that's where my mind goes.
Hmm.
When do you think is the good time? I mean, of course, it may depend on your blood work, but in general, would it be in your early 30s? Would it be in your mid 30s?
I mean, I don't think if you're symptomatic or not symptomatic yet, I mean, I think by mid 40s to 50 or so, I think that would be a good time to really start looking into that. If you're not having any symptoms yet, you could certainly get evaluated.
Mm-hmm.
But really staying within, there are benefits that occur years before menopause happens. And we don't know when that's, when our period's going to cease. Or like we talked about earlier, there's women that don't know when they're going to officially have their menopause. So
Hmm.
being in that, you would be pretty safe. There is a cluster of women that there's premature menopause and there's early menopause, and that's when that happens before 40 and before 45. So 45 on up is like normal range, 45 to 51 where the average is. Even some women go up to like 55 until they're menopausal. But really like 45 and after is when like the normal menopause or perimenopausal into menopause transition is occurring. So in that range, if you're looking at the preventative sides, like I think that's perfectly fine in that range there. But then the women that have started to have any kinds of symptoms, like, why wait? You know, they're not going to improve. You know, you can try other products. People, you know, there's other herbs out there and there's other, you know, products, and they're using other medications off label, like SSRIs and like sleep medications and all this stuff to try to help with the sleep issues. But why not just give back what you're deficient in, right?
Yes, in the
In
bud.
a bioidentical way, which means it's what your body is used to seeing and producing. You know, it's still formulated in a lab, but it's the chemical structure that your body is used to seeing,
Mm,
right?
amazing.
Um, so that's where, like, why not introduce progesterone? Why not play with that for a little while? And then maybe, you know, depending on what your other symptoms are, bring in estrogen. And testosterone is also, it's incredibly helpful for a subset of women. It's not the magic bullet for every woman. Usually estrogen, most women, like, you know, love it, and it works with them for something, you know, it's helpful for something.
Mhm.
Testosterone, there's kind of it's more of a subset of women, but when it works well, it works fantastically.
Mm.
For me, it was my motivation. It just skyrocketed when I got onto the right dose for myself. It just, I was in this lull, and when I picked up the higher dose of what I was on something, and I was, you know, learning myself, and I'm like, oh, I really want to try the dose that this urologist uses, and she finds that's great for most women. For me, it was like I was maxing out in the gym again. I was not plateaued in the gym, and
Mm.
my motivation was like through the roof. So for me, that's what happened. It does
Yeah.
also take a little bit longer. Testosterone seems to, like, not have as much of an impact as quickly as the others do for most women. But
Mhm.
progesterone and estrogen, they seem to work pretty quickly on average,
Yeah, I was
you know,
going to
within a
ask.
couple of weeks.
Okay, a couple weeks. I didn't know the turnover time of when you would start seeing and realizing some changes that are happening.
Progesterone works pretty quickly, a few days to a couple weeks for progesterone typically. And we talk more about that. But estrogen, there's like the two camp, there's the two, three camps. The super lucky women that see a difference in a few days, the average amount of women that see 2 weeks, which is still great, and then the women that it could take two months. But even still, I mean, 2 months is 2 months. It's not crazy long, but, you know, I know when you've been suffering, like, you want the relief right now. But it's
Mhm.
like 2 days, 2 weeks, 2 months are kind of like the camps when it comes to estrogen. But still, like, it's pretty fast.
Yeah, I mean,
So
considering how long you can be dealing with the symptoms, or 2 months is not very long at all, especially if you think about any lifestyle changes you're making. Things always take a little bit extra time, you know, you tell your body integrates, but something like that, that's pretty darn quick, I would say.
yeah, and testosterone can take a little bit longer. Average, I would say 2 months, but it can be up to like four to six at the higher end, but just
Mhm.
depends. And that's where we're playing with the doses and asking you, okay, do you feel more comfortable increasing? Do you want to overshoot? Would you rather me give you a little bit more? And if you feel like, okay, that's a little too much, we'll back down. Or would you rather start lower and slower? You know, that's where those conversations come from. And again, it's just, we don't have that conventionally. You don't have that time. You know, it's not built to be able to talk that way with your patients and really sit down and be like, I want to know everything about you. I want to, you know like what's going on in the interplay, and however much you want to share with me. And that's what I truly like, love the connection. Like, that's why I went into medicine. Like, I wanted to really truly get to know people and meet people, and to be in this space with women, to be able to really, like, tell you that I see you, I hear you, like, I want to give you a hug if you want to give me a hug, if you're a hugger. Like, that's me. Like, that's where I really, at this kind of like last phase of my not life, but my career, you know, I just, after 20 years of doing it that way, I want to do it this way, my own way, and know that I can really help women and feel that satisfaction of, like, really being able to make a dent in our local, you know, state college in Pennsylvania community.
Yeah, I dig it. I mean, 1,000%. Any time that a practitioner of any field that we go to for a certain answer, for help and for guidance, and to enhance our health, to feel better, to have longevity, to not suffer through symptoms and things that are hindering our day-to-day enjoyment of just being. That's what we want, is that conversation, the individual attention, the time spent, and it's just not feasible in the regular medical system. And there's a reason for it, there's a place for it, medicine, we need it. And when you're talking about the time and individual attention that everyone has so been lacking, especially with something this important, is through the roof exciting. And so I hope that everybody hearing this knows that there are, if you are not local to State College, there's got to be someone else in your area. Do your research, search around. Maybe Lauren has some colleagues or people that she knows in other areas
Yeah,
where,
you can always reach out to me. Sure. Yep.
and otherwise, I mean, if local to State College or nearby, great. In person is always best, but virtual visits are also a
Hmm.
thing, correct?
Yep. Hmm.
So it's not
Well,
ideal,
virtual
but
hug.
virtual hug, yes, it's it's the second best. So what else would you like to share before we get too lengthy here? This is amazing information. I've learned a ton. I have a whole page of notes here. But what would you like to share about your intro into taking clients on? I know that you have the first couple
Yeah,
of
I'm starting on Friday. Yeah, I have a full schedule of clients starting Friday. And for the next, we're going into the holiday season. So I have some weekend hours too this Saturday and then for another couple Saturdays. And then the Thanksgiving week, the kids have a full week off for Thanksgiving this year, which is amazing. So I'll be taking a little bit of time then, but I'll certainly be ramping up more towards, in December and on. And it just, when you look at the availability, when it comes up, you just have to scroll over and arrow a little bit because it's kind of patchy here and there. But there is, I promise, there's lots of dates that are open. And the first appointment is an hour long and we really get to know each other and just sit there in a calm, very nice, pretty, comfortable,
it is very nice.
atmosphere that doesn't look like an office, a sterile office. And yeah, and I have plenty of tissues because it's inevitable, like when you finally get to a place where you're being heard after seeing, I think the average woman, I read a statistic once that the average woman sees like 8 different clinicians before
Oh
someone
my,
finally like listens. Like that's crazy.
that's
I mean,
maddening. Yeah.
the time, the cost, the mental, anguish, all of it. It's crazy. But so I definitely am equipped with with tissues. But yeah, it's a nice appointment to kind of get established and then know, okay, I'm not just looking at your sex hormone levels. I'm looking at, because I have this functional lens, like I want to look at some other markers too if you haven't had them recently, vitamin D, your insulin level. Like I want to see all of these, a cortisol level, and there is one a la carte option as a testing that's a functional test that I'll explain, that there's no pressure at all to do, but it's if you want that additional insight. And I explain kind of what I can see from that testing, if it's something that it's a one-off, test that you want to have done as well. So yeah, it's just a very different perspective and different environment, and the way that I wish we all could have our healthcare, which is not the case right now. If things can certainly turn around, that would be great. But this isn't conducive to kind of chugging out patients. That's not what I want to do. I want to really have my core of women that I'm supporting, that they feel supported, that it's my tribe and the women that I just love coming to work because I want to be sitting there and having these conversations and knowing everything about them and how I can really navigate with them this journey to make them feel their best.
Yeah, beautiful. That's what's going to make the biggest impact. Absolutely. And guys, this is an assault spa, right? So there's what other components are there to the building that you're in?
Yeah, it's actually a wellness center that's being built. I'm on the third floor. There's a nutritionist who does gut health. There's a craniosacral therapist, Katie Rasmussen. Mary Kate Fuller is the integrative nutritionist. We're going to have an aesthetic physician assistant. Her name is Nicole Wolf. She's based out of the Bellefonte area right now. She's fantastic. And we're also going to have another holistic health practitioner, Brandy Norfolk. So that's our third floor. We have one more office if anyone is in the space and is interested. And then the second floor right now, there's 2 different suites. The one is unoccupied, and then the other one is two massage therapists, and then also two hairstylists.
Amazing. This could
Yeah,
be a full, come in for a
yeah.
full
You can
weekend
stay
or
all
stick
day.
around. Yeah. Bought from third floor to second floor and
Yeah.
get the full treatment. Well, I'm excited. I'm excited to check it out. The 14th is when you're open. And everyone, thank you. If you have any questions, like I can just full circle come back to it. Make sure you put them in the comments. Make sure you reach out. If you prefer to put your question or your comment in Messenger, then I can forward it on to Lauren, or you can message her directly in her Messenger. but we want to make sure that your questions are answered. And this was a lot of absorbing on my part, and
Yeah.
and
Yeah.
I loved everything that you'd shared. It's opening my eyes to how important this is, and I applaud you for starting this. It's your passion. Clearly, it is your heart to serve women in this way, and it's going to make a big impact. We have the We Connect conference that's coming up on is it the 21st
Yes.
of
21st. Yep.
November?
Hmm.
Um, so local women who are in the area or nearby, whether you're an entrepreneur or not, if you are just looking to be connected, we're both going to be there,
Hmm.
and you'll get to meet other women who are just moving and shaking, making things happen, making things change, and just improving our humanity, one one health visit at a time, or one way to level up your health, or become a better person. Business groups are involved with that to scale up and level up your business. It's going to be a great event. So I know that I'll be seeing you there next.
Sure
And
will.
yeah. So guys, have a great night, and thank you so much
Thank
for.
you, everyone, for listening. Thank you, Rachel.
You're welcome. See you guys soon.